Hello everybody, I'm Ulrich Sydney, and today we have the first of many lectures in our spine module. Before we start, as usual, we're going to present all the panelists. We'll start with Dr. Gembu. Can you present yourself, please?
Hi everyone, I'm Gembu Stefan, General Physician in Cameroon.
Hi, nice to have you. And then next up, Dr. Nuru. Dr. Nuru, please.
Hi everyone, I am Dr. Nuru. I am resident in neurosurgery. Nice to meet you all.
Nice to meet you. Nice to have you here. Dr. Igor. Dr. Igor Nietzsche.
Yes.
Can you present yourself?
Okay, Dr. X, thank you. Hello everyone, my name is Igor Nietzsche. I'm from Cameroon. I'm resident in neurosurgery in Nashville.
Yeah, so Dr. Sorry, you were breaking, so I'll just repeat what you said. So Dr. Igor Nietzsche is a neurosurgery resident currently in Cote d'Ivoire, Abidjan, and he's originally from Cameroon. Nice to have you. Next up, Arsène Daniel.
Hello, everyone.
Hey. Yes.
Hello, everyone.
Hey, we can hear you. Present yourself, please.
Arsène Daniel from Université Catholique de Bukavu in Democratic Republic of Congo. I'm a medical student in the final year, and I'm also involved in AFAN as a member. It's a great pleasure to be a part of this meeting today. Thank you.
Well, thank you very much. So next up, Ndale Geneviève.
Good evening, everyone. My name is Ndale Geneviève, fourth-year medical student in the University of Boya. Nice to participate with you.
We're happy to have you. We want to have more female members here. So if you have friends who are interested, please let them know that we're waiting for them. And then next up, Dr. Abdulaziz.
Hello, this is Abdulaziz from Ethiopia, fifth year neurosurgery resident from Black Line Hospital.
Hi, nice to have you.
Thank you. Thank you.
Dr. Kabulo.
Hello, everyone. My name is Kabulo from Democratic Republic of Congo. I'm final year neurosurgeon resident at the University of Zimbabwe. Nice to meet you all.
Always nice to have you. The great Zolo Ivan. Awesome Zolo Ivan.
Hello everyone, I am Zulu Ivan. I'm a senior medical student from the University of Boya, a member of AFAN, and it's a pleasure for me to be here.
Yeah, thanks Zolo. Dr. Kennedy, can you present yourself, please?
Hello everyone, it's Kennedy Kimani, a third-year neurosurgical resident from University of Nairobi, Kenya.
Nice to have you, Dr. Kennedy.
Yeah, it's a great pleasure to be here.
And then Dr. Aminata Salah.
Hello, I'm Aminata Salah. I'm originally from the Gambia, residing in Namibia and training in Zimbabwe. It's an honor to be here. Thank you.
Well, thanks. A true Pan-Africanist with experience as well.
Thank you.
Okay, so finally it's my turn. So I'm Ulrich Sydney, as you can read on the screen. I'm the president of the Association of Future African Neurosurgeons. I'm currently a research associate at the program in global surgery and social change at Harvard Medical School. So today we're going to have the first of many presentations in a spine course by Dawin Sichimba is going to present himself. So please, Dawin, go ahead. I will be sharing the screen for you.
Thank you so much. It's a privilege to be part of this team. My name is Dawin Sichimba. I'm a fifth-year medical student from Copperbelt University Zambia, and I'm a member of the Association of Future African Neurosurgeons. So today I'm privileged to be the first to present in this spine and spinal cord course on the topic surgical anatomy of the craniocervical junction. I should mention that I think this was one of the most challenging presentations in terms of preparation that I've ever done under FAN, but I think it's going to be fun presenting here. So please bear with me in case the slides are a bit clouded because I didn't really know which was important and which was not so important to include in my presentation. Thank you. Okay, so that is my outline. So I'm first going to look at the embryology, all right? The embryology and developmental anatomy. Then we look at the atlas and the axis embryology, ligament embryology, then chondrification and ossification of situ vertebra and radiology. Then we look at anatomy and biomechanics. Also look at the occipital bone and the Atlanto-Occipital joints. Then from there we'll proceed to look at the Atlanto-Axial joints, then the craniocervical ligament. Then from there we'll look at the vascular supply, nerve roots, physiological biomechanics, then the normal, some of the normal variants of the cranial cervical junction. Then you look at some of the fixations that are done when you're looking at the craniocervical junction, or rather the craniovertebral junction. Then we shall look at the different the references. Okay, next slide. All right. So as an introduction, first of all, look at the definition of the craniovertebral junction, or rather the craniocervical junction. So the craniocervical junction, which is also called the craniovertebral junction, is a complex region where the skull and the upper cervical spine connect. Okay, so the connection between the brain and the spinal cord is at the base of the brainstem in the region of the craniocervical junction. All right, so this craniocervical junction is comprised of the inferior surface of the skull, the atlas, the axis, as well as the muscles, the connective tissues that attach the skull to the cervical spine, right? And the cervical spine is the first portion. So in addition to neuro and vascular structures, the majority of cranioflexion, extension, and rotation is accomplished at the craniovertebral junction, or what we're calling the craniocervical junction. Okay, so something that we should take note of is that the craniocervical junction is a distinct osteoligamentous entity with specific functional demands. Right? That is something that is very, very important to take note of because of its structure and it's the things that it houses. So it has specific functional demands. So the craniocervical junction encloses the central nervous system, the encephalic vasculature, and the cerebrospinal fluid system, like I mentioned earlier. So one thing that is important to note as we look at the craniocervical junction is that congenital and developmental osseous anomalies and abnormalities that affect the craniocervical junction can result in neurocompression, as well as things such as vascular compromise, and this can manifest with abnormal cerebrospinal dynamics. So now, malformation and misalignment of the craniocervical junction can cause a constellation of cerebral and other neurological signs and symptoms, collectively called the craniocervical syndrome. So these signs and symptoms that arise due to the malformation and misalignment of the craniocervical junction are what are called the craniocervical syndrome, or rather CCS. Okay, so the knowledge, or rather our knowledge of the embryology, developmental anatomy, and the biomechanics of the region is vital for understanding these problems. Is vital in understanding these problems is derived from and the subsequent approaches in patient evaluation and management. So what we're trying to say is that when we know the embryology and developmental anatomy and the biomechanics of the craniocervical junction, we are going to know some of the problems that arise with this particular region, and we are also going to know the subsequent approaches in patient evaluation and management in case of any particular pathology. So the signs and symptoms of craniocervical junction syndrome may be due to mechanical strain, curvature, and other structures of the cranial vault, resulting in irritation and dysfunction of the affected tissues. So now, this deformation of the craniocervical junction may also obstruct blood and CCF flow, like I've already mentioned. And this is going to result in chronic ischemia, edema, things such as hydrocephalus, can cause degenerative cascades that can in turn lead to neurodegenerative diseases. Okay, so let's look at the embryology and developmental anatomy. Okay, so this is something that is very important to understand. Hopefully, much of the important information concerning this aspect of the craniocervical junction is included in my presentation. So the bony cranial base is developed by the process of enchondro-ossification. Okay, enchondro-ossification, in which the cartilaginous framework is first developed and subsequently reabsorbed with further deposition of bone caused by distorting forces, right? Caused by distorting forces such as eye development and brain development. Next slide. Next slide. Hello?
Hey, Dawin. It seems your connection is breaking.
Okay. Growth at it. Okay. Where can I start from? Is it okay? I repeat on this slide.
Yes, it's better. It's much better now. Go ahead.
Okay. All right. So I was saying the clivus and cranial base elongates by suture growth at the spheno-occipital and this spheno-petroso synchondrosis. All right. And by further suture growth along the lateral portion of the cranial base. So on the other hand, the facial bones and the majority of the cranium develop by intramembranous ossification. This development bypasses the intermediate cartilaginous phase are characteristic of the development of the bony cranial base. So, I should make mention that this particular portion develops from the mesoderm. Okay, so this mesoderm eventually separates into two segmental clusters, which are called the somites. Okay, so when you're looking at that development, it originates from the mesoderm. Now, this mesoderm is going to separate into segmental clusters, which are calling the somites. Okay, so now this paired somites. So the number usually in humans is about 42, but it differs from species to species. But in humans, it's about 42 pairs. All right. So these somites will eventually give rise to the smooth muscle of the dermis, exoskeleton, musculature, and the vertebral column, among other structures, of course. So now, these somites, remember we said that there are about 42 pairs, okay? So these somites, they are divided, there are different divisions of these somites, okay? So the first portion, we have what are called the occipital somites. So there are 4 of them. Then we have 8 cervical somites. Then we have 12 thoracic somites. 5 lumbar somatic somites. Then we have 5 sacral somites, and about 8 to 10 coccygeal pairs of these somites. So each somite differentiates into an outer dermatome, an inner myotome, and a medial sclerotum. So we have the outer, the inner, and the medial. Okay. So the outer one is the dermatome. The inner one is the myotome, and then the medial one is called the sclerotum. All right. So those are the different differentiations of the somites that we have mentioned. So the sclerotums are ventromedial in their location, and will eventually form the vertebral bodies, neural arcs,
Hey, Dawin. Dawin. I think we might have lost him. Let me see. No, he's still there.
ligament.
Connection isn't the greatest. Try and text him. Yeah, well, I've sent him a text message. We'll see what he says in the meantime.
Hello?
Oh, there you are. Hey.
Okay, sorry, I think I had a network problem.
Yeah.
I hope it normalizes shortly.
Yeah, go ahead.
Where can I continue from?
This slide. From ventral medial, the second point.
Okay, all right. So what I was saying is that, remember I've mentioned that the somites differentiate into 3 layers, that is the outer dermatome, the inner myotome, and the medial sclerotum. Now, the sclerotum, which is the medial layer, they are ventromedial in their location, all right, and will eventually form will form structures such as the vertebral bodies, the neural arcs, ligaments, and the membranes, as we shall see when we look at the gross anatomy. Okay, next slide. Okay, so these ventromedial bilateral cells migrate towards the midline and surround the notochord. Okay, so each sclerotom will develop the fissure of Ebner, which is a central cleft that divides a loose collection of cells cranially from a dense cellular area caudally. Okay, so what we're saying is that this sclerotom is going to develop into that fissure. This is a central divides a loose collection of cells that are cranial from dense cellular area. Next slide. Okay, so in this development, the cells from the fissure of Ebner migrate toward and encase the code to become this forms. Hello.
Sorry, Dawin. It's just that the connection has been really really unstable, so we've lost you. Let's.
Okay. Okay. Give me just a minute. Maybe I try my other network.
Okay. Great. Okay. Please do that.
Yeah.
While I'll do this, we'll just pause the recording. Please go ahead.
Okay, thank you so much. Apologies again for that. Okay, so I was saying in this development, the cells from the fissure of Ebner migrate towards and encase the notochord to become the precursors of the intervertebral disc. All right. So the superior half of one sclerotom unites with the lower half of its neighbor, and thus forms the earliest manifestation of the vertebral body. Next slide. Okay, so the first four sclerotoms, however, will not follow this course. So remember, we said that the superior half of one sclerotom unites with the lower half of its neighbor. All right, and forms the vertebral body. Now, the first four sclerotoms will not follow this course and essentially fuse to form the occipital bone, posterior portions of the foramen magnum. Okay, so simultaneously, vascularization of the occipital bone begins, and differentiation of the ganglia and vascular tissue begins as well. So the hypoglossal and first cervical arteries demarcate the caudal-occipital segment. Next slide. So as that is happening, the nervous system also begins to differentiate. All right. So during the 5th and 6th weeks, further differentiation of various parts of the brain and spinal cord also occurs. Okay. The roof of the fourth ventricle, however, thins out in the midline to form the foramen of Magandi, and laterally to form the foramen of Lusca. So this occurs as an opening in the approximately the 7th week, when a connection between the fourth ventricle and the subarachnoid space is established. Okay, so let's look at that diagram. We can go to the next slide. Okay, so this diagram is showing more like 4 stages or 4 portions. So in the first stage there on part A, this is after the forging of the embryo during the 3rd week. Okay, so the paraxial mesoderm migrates to develop the notochord and divides into sclerotomes. So those are the sclerotomes that are developed when we look at part B there on the diagram. Okay, so each sclerotome differentiates into a cranial loosely arranged portion. Okay, that is 1, and a caudal compact portion, that is 2. Okay, so there are 2 portions, that is 1 and 2, the cranial loosely arranged portion and the caudal compact portion. So the compact caudal portion of each sclerotome fuses with a loose cranial portion of the adjacent sclerotome to form the vertebral bodies, like I mentioned earlier. The most cranial part of each compact portion fuses, forms an intervertebral disc, as we can see on part C, the sphere portion there labeled 3. Okay, so the neural arcs are formed by a dorsal migration of sclerotome elements, completing the membranous vertebral column. So this is followed by chondrification and eventually ossification of the vertebra. So as we can see on part D there, there is a formation of the vertebra. Okay, we can go to the next slide. So that is that diagram on the next slide. Okay, so the next slide, this slide is basically showing almost the same thing as from the previous slide. So you can see the fourth occipital sclerotome, the first cervical sclerotome, and then we have the second cervical sclerotome. So we can see that there's fusion there to form eventually to form the vertebra. Next slide. Okay, so in relation to biomechanics of the craniocervical junction and the impact of trauma on this structure, it is useful to visualize the craniocervical junction as composed of 2 components. Okay, so when you look at the relation, when we're basically concentrating on the biomechanics and the impact of trauma, it is very important, according to research, it is very important to view this portion as composed of 2 components. So that is, the first is a central pillar consisting of the central basal occiput, even though it is anatomically part of the skull. Okay, and this first portion is this first component is also composed of the odontoid process, that is the dens of the peg, and the C2 vertebral body. Okay, so the first component of this craniocervical junction in relation to biomechanics. Okay, so this component is the pillar consisting of 3 things basically. That is the central basal occiput, which is part of anatomically part of the skull base. Then we also have the odontoid process and the C2 vertebral body. Okay, you can go to the next slide. Then the second component, all right, the second component is consists of two rigid structures surrounding the central pillar. So in the previous slide, we talked about the central pillar, all right? So now we have two rigid structures that are surrounding the central pillar. These are the ring of the foramen magnum, okay, including the lateral portions of the basal occiput, the occiput, incorporating the occiput condyles and the ophidian, the posterior margin of the
Hello, Dawin. Yeah, perhaps we lost him again. Oh, he's muted.
Hello.
Hey, you were muted.
Okay.
All right.
Okay.
So you had we lost you at ophidian.
Okay.
Ophidian. You were describing what the ophidian is.
Oh, okay. Okay. All right. I can continue from there then.
Hello.
Hello.
Yes. Go ahead. Go ahead.
Okay. All right. So I was saying that the second component, okay, consists of the two ring structures surrounding the central pillar. These are the ring. These are the ring of the foramen magnum, including the lateral portion of the basal occiput, the occiput, incorporating the occipital condyles and the ophidian. That is the posterior margin of the foramen magnum, and the ring of the C1 vertebra, that is the atlas, consisting of the anterior and posterior arcs and the lateral masses of the atlas. Next slide.
It's the next slide. You can go ahead. Yeah, it's a bit difficult to follow. Right. Okay. So, Dawin. Hello, Dawin.
Hello, Dr. Sydney.
Yes, yes. So we've been cut a few times. I think what we can do now is hoping that the network would change a little bit, maybe we give it a short pause now, a little bit of question feedback, hoping that the network will be better in a few minutes. Is that okay with you?
Okay. Yeah, that's okay. That's okay.
Okay. I think that way, but definitely this network is a lot better than the first one. So I'm hoping we can get a more fluid connection in a few.
Yeah, minutes. I really hope so.
Yeah. So I would say before we go ahead, I'll leave it up to the more senior people first. We have Dr. Marco Meloni who's around, so that's awesome. Hello, Dr. Marco. Hi.
Hi, Eric. Hello, everybody. Yes.
Hi. So I'll leave it to the most senior members first. If you have any feedback, please go ahead and give it to Dawin. So far, is there anything you'd like to highlight?
Well, actually, nothing, Ulrich. First of all, I want to congratulate with you for your project. It's absolutely wonderful because in a neurosurgical activity, the scientific aspect is very important. It's something that enrich yourself and is a stimulus to do more, better and better every day. So absolutely a great project. It was very, very enthusiastic. I think about my group. Stefan Nguembum can talk for us, but we choose the neurotrauma as topics. And I think we can find some interesting subtopic about that. I was discussing with Nguembo, but I think we have already idea about the project we aim to do.
Okay, that is awesome. I am definitely looking forward to the different scientific products from these groups. This will be for a lot of our members. It's going to be the first time they participate in such activities. So it's a good learning process, and like you said, it's also a good learning process for them as in neurosurgically to learn about something maybe that you didn't necessarily know about. Thank you so much, Dr. Marco. So I would say, yeah, so that was about the research project. So Dawin, in the first part of your presentations, just the feedback about it, I'll say, generally speaking, your slides are busy, so they have a lot of text. What you want is really be light on the text. A rule of thumb is the rule of sevens. So if you type on Google, you type slides or PowerPoint rule of 7. Try not to have more than 7 words in one line. Try not to have more than 7 lines on one slide, okay? Just try as much as possible. Remember, your audience should not be reading the text along with you, okay? The text is there to remind you what you read. Your audience should be captivated by you, okay? So they should be listening to you. So when you see a point, you're like, oh, okay, I had to talk about this and I had to talk about these other things. So you keep it really light on the slides. Next thing is you want to animate the slides. When we're speaking about anatomy is a lot about seeing. We have to visualize. So try as much as possible to get images. Each time you're illustrating something, have an image. You can have a video. We're so lucky today. We have applications online which are free. You have other videos and textbooks you can access. Try and have them. And even for yourself, you can try and sketch a few of them. You yourself, you can sketch a few diagrams, okay, to portray, and it helps you have that spatial memory, okay. Yeah. So I'll definitely say that so that the other comments I will keep them for the end. The really positive thing is it's clear from your presentation that you've done a lot of work. It's awesome, amazing. When you see the presentation, you see the quality. Your introduction is very detailed. It covers so much information. Embryology is perfect. You've gone back to the understanding of how we have the spine and spinal column, the spinal column essentially. And that's important, very important to understand pathologies of the spine, and especially the craniocervical junction. Very important. So that, I mean, it's more than brilliant. With this kind of a spirit, I mean, you can only be a great neurosurgery resident and a great neurosurgeon. So just keep it up, Dawin. Keep it up, definitely.
Thank you so much, Dr. Ulrich, for that.
Yes, thanks. Yes, Dr. Marco, please go ahead.
Yeah, first of all, I absolutely agree 100% what you just said. We need to remember that a public is more attracted if you show picture more than some writing. As you told, words are useful to to give the concept, the topic of the slide. So you're talking, for example, about far lateral approach, for example. So you put the picture and you put far lateral approach, so, but is enough. A suggestion I used to do is when, because sometimes the topics are very large, and sometimes even if you know, usually don't do far lateral approach, for example, is the first topic I talk, is useful. You put some writing down notice like this. Sometimes I put I try before the panel. I try to talk to discuss the panel. I take some notes in writing, so I don't fill the slide, but I have some notes to remember me what I have to say. That's a suggestion I used to do.
Yeah. Yes, and this advice from Dr. Marco goes to everyone. Remember, we have many objectives we're trying to hit here. We want to make sure that our members are learning about neurosurgery. We want to make sure you're comfortable presenting, because it starts today, but tomorrow you'll be at international conferences. We want you to be there and really kill it. Let everyone see that you have that experience, and each time you're getting better. So for the future presenters, please take these notes and make sure you apply them to your own presentations. And the more we do this, the more you become comfortable in your presentations.
Yeah, of course, but this panel are also a school of presentation, so it's absolutely experience, and everybody of you, me at the first one, can learn from doing presentation.
Thank you so much, Dr. Meloni. So Dawin, let's try again. Hopefully now we've had you. Your connection is a little bit more stable, so you can go ahead, hopefully. And
okay, sure.
Yeah.
Okay, so I think I've noted on the issue of the slides being clouded. Okay, it was just quite hard to remove out some things, but something that I've noted, and I'll work on that next time. Mm-hmm. Okay, so I can continue from that slide, right?
Yes, yes.
Okay, so I was saying that functionally, the lateral stacked two-ringed component allows limited rotation around the central pillar, as well as the intrinsic limited flexion extension. Okay, so the ligaments behind these two structural components of the craniocervical junction provide stability. So when you look at those components that I've mentioned in terms of biomechanics, there are ligaments behind them which provide stability. Okay, so let's look at the next slide. Next slide. Okay, so when we look at this diagram, it's simply illustrating the anatomy of the craniocervical junction, ligamental structures. Okay, so a right lateral view of this is a right lateral view of the sagittally sectioned craniocervical junction in a median plane. Okay, so you can see the various structures of the craniocervical junction. We can see the foramen magnum. We have the lateral aspect, the posterior aspect, and the anterior aspect. Then we also have the membrane. We have the ligaments that are being shown in that diagram. Right. Okay, we can go to the next slide. Next slide. Okay, so when you look at this slide, it is just a posterior view of the previous diagram. Okay, so so when you look at the posterior aspect, like I mentioned, we have those components, the two components that we talked about. Then behind them, or the posterior to those structures, we have those ligaments that are providing stability. Okay, so we have, for example, we have the cruciform ligament, which is also posterior to those structures. We have the posterior longitudinal ligament. We also have ligaments such as the ala ligament. So all these ligaments are providing stability to the craniocervical junction. Next slide. Next slide. Okay. So the lateral zone of the first cervical sclerotum develops into the posterior arc of the C1 vertebra, while the lateral zone of the second cervical sclerotum develops into the arc of the axis. So the anterior arc of the C1 vertebra develops from a small mesenchymal offshoot ventral to both the notochord and the axial segment of the first cervical sclerotum, which is called the hypocaudal bow. Next slide. So the hypocaudal bow of the pro-atlas gives rise to a small osseous midline tubercle attached to the ventral surface of the basal occipital, the basal occiput below the anterior margin of the foramen magnum, okay, which is called the bastion, and it's frequently visible, especially on CT scan or MRI of the mature normal craniocervical junction. So the apical ligament is derived from the axial pro-atlas. Okay, so remember I talked about the precursor of the atlas. Okay, so the pro-atlas gives rise to the apical ligament, as we shall see later on when you look at the ligament. So this is under development of the ligaments that are involved in the craniocervical junction. So when you look at the gross anatomy, we're going to look to see the various ligaments that are involved. So the apical ligament is derived from the axial pro-atlas. So the ala ligament and the transverse ligamentous component of the cruciform, or rather the cruciate ligament, develop from the axial component of the first cervical sclerotum. Next slide. All right, so let's look at the chondrification and ossification of C1 vertebra and some radiology. Okay, so the membranous C2 vertebra in the early part of the first trimester consists of 3 median segments. Okay, so that is one, we have the apical dental segment, then you have the basal dental segment and the body of the axis. So those are the 3 segments that are seen on the C2 vertebra. So these 3 segments chondrify at 6 weeks of gestation, but remain segmented by the upper and lower dental synchondroses. Okay, so ossification occurs in 3 stages. So these 3 stages are as follows. One, we have the first ossification center appears in the body of the C2 vertebra at 4 months of gestation. Then the second wave of ossification appears at about 6 months of gestation as 2 ossification centers So these osciillation centers, we have one on each side of the basal dental segment. So remember, we've talked about the three segments of the C2 vertebra that are seen in the early stages of the first trimester. Okay, so now these two centers integrate and fuse at birth when they should have begun to show some attempt at osseous fusion, but the non-ossified cartilage may still be evident radiologically into the 6th year of life. So some of them they may remain without being ossified yet until the 6th year of life. So now the third wave. So remember we've talked. I mentioned that there are three oscillation stages. Okay. So the third stage is the third wave of oscillation appears in the apical dens at 3 to 5 years of age. Okay. So oscillation in this case of the apical dens and the fusion across the upper dental chondrosis is not complete until adolescence. Okay. So what is seen is that, especially radiologically, this stage of oscillation, it persists up to about the 3rd to 5th year of life. So that is just a radiological diagram of the oscillation centers, the three oscillation centers that or rather stages that are seen when you look at the craniocervical junction. Okay, we can go ahead. We can go to the next slide. Next slide. Okay, so this table is just showing some of the anomalies, developmental anomalies that are associated with the craniocervical junction, and some of the suggested embryologic origins of those anomalies. So for example, just to mention a few, for example, we have the accessory occipital condyle, which originates from the pro-atlas. Then we also have a persistent ossiculum terminal, which also originates from the pro-atlas. Others, we have anomalies such as assimilation of the atlas, which is of course originating from the atlas itself. Then we have anomalies of the arches of the atlas. Then others, we have atlanto-axial segmentation defect, which is originating from the axis. Then we also have anomalies of the odontoid process, which is also originating from the axis. So those are, to mention it, but a few, those are some of the anomalies that are associated, rather developmental anomalies that are associated with the craniocervical junction. Next slide. Okay, so let's look at the anatomy and partly some biomechanics. Okay, so this, the cervical spine is made up of 7 vertebrae divided into upper and lower sections. So what we're saying is that this cervical spine, there are these 7 vertebrae, which each of them are divided into upper and this region is divided into the upper and lower section. So the upper cervical spine includes the first 2 vertebrae, which are classically called C1, which is the atlas, and C2, which is the axis. Okay, so those make up the upper portion of the cervical spine. Then the rest, C3 to C7, they make the lower portion of the cervical spine. So the craniocervical junction links the skull to the upper cervical spine. Okay, so what we're saying is that when we look at this craniocervical junction, it is making a link between the atlas and the axis, or rather, it is connecting the atlas, the axis, to the cranium, or rather to the skull. Okay, and it also also forms what is called the foramen of magnum, okay, or rather connects the foramen of magnum to the spinal canal. So now, the craniocervical junction is composed of two major joints, okay? So there are these two major joints that are very important when you look at the biomechanics and as well as far as surgery is concerned. So we have one what is called the ATLANTO-OCCIPITAL joint, okay, which is between the occiput and the atlas, or rather between the skull and the atlas. Okay, that is the first cervical vertebra. Okay, then we have the joint between the first and the second cervical vertebra, which is called the atlanto-axial joint. So these two joints are responsible for the majority of the movement available in the entire cervical spine, and the anatomical structure of each is based on different biomechanical principles. So these two joints are the ones which contribute much to the mobility of this particular region. Okay, so these diagrams are showing parts of the first vertebra and the second vertebra. So like I mentioned, the first vertebra is called the atlas, the second is called the axis. So on the axis, we can see there we have the anterior arch, okay? We also have the posterior arch, then we have the lateral mass and the transverse process. If you look at the diagram there, okay? Then the axis, we can also see those parts. These are radiological structures. So when you look at the next slide there, we can go to the next slide. So the next slide, this is a schematic diagram, which is also showing the parts of the atlas and the axis, okay? You can go to the next slide. Okay, so this is a radiological image, which is a coronal 3D dimension T2 space. Okay, so now when you look at this slide, we can see that it is basically showing also this particular portion of the craniocervical junction. Okay, next slide. So now let's look at these joints a bit more into details. The joints that I mentioned, the two joints that are involved, or rather that are found at the craniocervical junction. So the first joint that I mentioned is the joint between the occipital bone and the atlanto-occipital joint. Okay, so we have the occipital bone and the atlanto-occipital joint itself. So the occipital bone encompasses the foramen magnum and extends from the clivus anteriorly to the lambdoid suture posteriorly. Okay. Now, this the occipital condyles angle medially and inferiorly from the posterior to anterior. Now, this angulation limits the mobility of the atlanto-occipital joints, that is C0, C1 joint. Okay, so the occipital bone is being called the C0, then the atlas is the C1. So that junction, what we can see is that the occipital condyles that are angling medial are the ones that are more like limiting the mobility of this particular joint. Otherwise, if these condyles are not there, then we may find that there may be abnormal mobility in that region. So particularly in the axial rotation compared with the atlanto-axial joint. So there's less mobility in this region, or rather on this joint, compared to the atlanto-axial joint, which is the C1, C2 joint. Next slide. Okay. So we can see that the predominant, when we look at still look at this particular portion, or rather the occipital bone and the atlanto-occipital joint, we can see that the predominant movements at the atlanto-occipital joint are flexion and extension. Okay, so basically much of the movements that are found on that joint, it's just flexion and extension. There may be other minimal movements on that region, but much have to do with flexion and extension. So lateral flexion at the atlanto-occipital joint is significantly limited by the contralateral ala ligament, which I talked about under embryology, and we should also look at it under gross anatomy. Okay, so let's look at the next joint that we mentioned. We have what is called the atlanto-axial joint. Okay, so the atlanto-axial joint, which is C1, C2, allow mobility in flexion, extension, axial rotation, and to a lesser degree, lateral flexion as a result of the biconcave and inherently unstable construct of the joint. So compared with the other joints, the occipital atlanto joint, we can see that here there is much more movement that is allowed on this particular joint. Okay, because on the other joint, we can see that there was only flexion, or rather much of the movement, there was flexion and extension. But in addition to that, on this joint, we also have axial rotation as well as lateral flexion. Okay, so it is the ligament, that is the transverse ligament and the ala ligament, related to this particular articulation, which stabilize the joint complex. So in as much as there's quite some significant movement on this portion, or rather on this region is stabilized by basically by two ligaments, that is the transverse ligament and the ala ligament. So to continue with that, we can see that in the event of traumatic disruption of these ligaments, okay, the atlanto-axial ligaments are poorly equipped to tolerate axial rotation. Okay, so this is in stark contrast to the atlanto-occipital joints, which are less affected by the ligamentous injury. So remember, I said that there are basically two movements that are found on the occipital atlanto joint, that is flexion and extension. But in addition to on this one, there's also a rotation. So because of that, when there is that ligamentous disruption or the injury, the one which is affected the most is the atlanto-axial joint. Next slide. Okay, so let's look now at the craniocervical ligaments. What are some of the ligaments that are found in this region? So there are quite a number of ligaments. There are about 8 of them that are well described, but some of them they are only seen, especially on dissections. Others are not significant enough, especially in a case of injury. If that particular ligament is injured singly, we find that there's no significant damage that is done, especially or other manifestation clinically. Okay, so in this presentation, I'm going to talk about 8 ligaments, but there are also others that are mentioned. Okay, so we have, for example, there we can see that we have the tentorial membrane. Then we we also have we have the hypoglossal canal, the foramen magnum there. Then we have what is called the accessory atlanto-axial ligament. Okay, so that ligament is very, very important. The other ligament that is very important is what is called the cruciform ligament and the apical ligament of the odontoid process. Okay, the other ligament that is worth mentioning is what is called the transverse ligament, which I'm going to describe them in a bit more details as we go along. Okay, so we can also see that we have other ligaments such as the capsular ligament, we have the apical ligament, and so on and so forth. We also have the accessory ligament and the transverse band of the cruciform ligament. Okay, so let's look at the ala ligament on the next slide. Okay, so the ala ligament, these pair ligaments attach the axis to the base of the skull and originate from the posterior surface of the upper third of the dens, and typically travel caudocranially, that is in about 50% of cadaveric dissections, and horizontally in about 50% of subjects. Okay, so the exact insertion point of the ala ligament has been subject to some contention, with researchers variably describing insertion on the medial aspect of the occipital condyles or the anterior lateral aspect of the foramen magnum. So different researchers have described this in a bit different way, but mostly we find that in about 50% of cadaveric dissections, we find that it travels caudocranially. Then in about 50% of subjects, it travels horizontally. Okay. Now, each ligament is let's go to the next slide. So each ligament is narrowest at its origin and comparatively wider at its insertion, okay, giving a V-shaped configuration, all right? So the other ligaments limit axial rotation and lateral flexion on the contralateral side. And apart from the transverse ligament, these are the strongest stabilizers of the atlas, preventing anterior displacement on the event of rupture of the transverse ligament. So in a case where there is a rupture of the transverse ligament, we can see that this ala ligament is also very strong and significantly stabilizes the atlas and prevents it from anterior displacement. All right. So together with the transverse ligament, the ala ligaments are primarily stabilizers of the craniocervical junction. These are the primary stabilizers of the craniocervical junction because of their strength and because of their placement, or rather their origin and their insertion. Next slide. Okay, so let's look at the second ligament. We have what is called the cruciform ligament, which is also called the cruciate ligament. So the cruciform ligament is composed of transverse and vertical parts, which form a cross behind the odontoid peg. So if I think there's a diagram that I showed earlier where we saw that there was that cross, a cross kind of structure. So that portion is what is called the cruciform ligament. Okay. So the vertical component, which is relatively weak and offers no discernible
Hey, Dawin. Hello, Dawin. Yeah, network issues. Hold on. There you go.
Okay, so I will start from the cruciform ligament.
Yeah.
Is it okay? Okay. I can't see the shared screen.
There's a delay. Just wait a bit and you see it.
Okay, sure. Okay, so I was talking about the cruciform ligament. So I mentioned that the cruciform ligament is composed of the transverse and the vertical parts that are seen behind the odontoid peg. All right. So the ventral, the vertical component, which is relatively weak and offers no discernible craniocervical stability, consists of a cranially oriented longitudinal band, which inserts on the upper surface of the cleavers between the apical ligament and the tentorial membrane. Okay, so we have the apical ligament and the tentorial membrane, and then it inserts on the surface of the cleavers, which is between those two. Okay, and caudally it inserts. It is direct. It is a directed band which inserts onto the posterior surface of the body of the axis. Next slide. Next slide.
Just a second.
Okay, so let's look at the transverse ligament. So the transverse ligament, which is also sometimes called the transverse Atlanto ligament of the cruciform ligament complex. So remember we talked about the cruciform ligament. So it is a complex, and some of the components we have this transverse ligament. Okay, so it is arguably the most important ligament in the body. Okay, so some researchers have mentioned that it is the most important ligament in the body. So it is the largest, thickest, and crucially the strongest of the craniocervical junction ligament, and in fact the strongest ligament in the entire spine. So we can see from its characteristics, its properties, we can see that it offers a very important function to the craniocervical junction. Okay, so it is the primary stabilizer of the craniocervical junction. So this transverse ligament, it attaches behind the odontoid process or the odontoid peg, attaching to a tubercle arising from the medial aspect of each lateral mass of the atlas. So this transverse ligament is central to stability of the craniocervical junction, like I already mentioned. Okay, so it is very, very important as far as stability of the junction is concerned. So fixing the odontoid peg firmly to the posterior aspect of the anterior arch of the atlas. So that is that's one of its functions. It fixes the odontoid peg firmly enough to the posterior aspect of the anterior arch of the atlas. So a synovial capsule is situated between the odontoid process and the transverse ligament. So the tentorial membrane, epidural fat, dura, and the dura are located posterior to the transverse ligament. So it is very important to take note of these structures, especially even during surgery, so that there's no disruption of those important structures. Okay, so the transverse ligament serves as a major stabilizer, like I mentioned, of the atlanto-axial articulation. It permits rotation at the atlanto-axial joints, while at the same time, the ala ligaments will prevent excessive rotation. So I think I mentioned this about the ala when I talked about it. Okay, so tears of the transverse ligament typically occur laterally at the attachment to the tubercle of the atlas. So let's look at the tentorial membrane on the next slide. So the tentorial membrane is a thin structure that represents an upward extension of the posterior longitudinal ligament. Okay, so it forms the posterior border of the supraodontoid space or apical cave, and runs posterior to the cruciform ligament. And it also extends cranially to the cleavers, as far cranial as the spheno-occipital synchondrosis, and caudally to the posterior surface of the body of the axis. Okay, so that is basically the orientation of this tentorial membrane. So this tentorial membrane is very important, especially when you look at the herniations and everything. It also prevents herniations, other than just providing some stability in this area. Okay, so let's look at this diagram on the next slide there. Okay, so this diagram vividly shows the cleavers, which I was talking about, and then like I mentioned, the cruciform ligament, it is forming more like a cross structure there. Okay, we have the vertical and the horizontal portions of the cruciform ligament. Okay, so the vertical one, it is attaching to the surface of the cleavers. Okay, and then we also have the ala ligaments, as we can see there, which are more like the transverse aspects of this this cruciform ligament. Okay, then we also have the odontoid process. As we can see, that the atlanto-axial ligament is attaching just to that portion of the odontoid process. Okay, we can go to the next slide. Next slide. Okay, so this tentorial membrane, it also attaches as far laterally. Remember, we've talked about
Hello. All right. Hey, Dawin.
Hello.
Hey, we lost you for a second.
Yes. Okay. Can I start from that current slide?
Yeah, go ahead.
Okay. So remember, I mentioned that this tentorial membrane, when you look at it vertically, it attaches, or rather it extends cranially to the cleaver, and caudally to the posterior surface of the body of the axis. All right. Now, when you look at the lateral aspects of its extensions, or rather of its attachment, we can see that it attaches as far lateral as the hypoglossal canals, and at the level of C0 and C1, it emerges with the atlanto-occipital capsular ligament, okay, which is also called the anode ligament. Okay, so the cranial portion of the membrane is adherent to and anatomically indistinguishable from the dura. So you can see that it's not so easy to distinguish it from the dura because of its adherence to the dura. Okay, so let's look at the capsular ligament on the next slide. So the capsular ligament of the atlanto-occipital and the atlanto axial blows. Okay. Then the fifth ligament that we can look at is what is called the apical ligament. So this ligament extends from the tip of the odontoid process to the basion and is situated between the anterior atlanto-occipital membrane and the cruciform ligament. Okay, it is surrounded by fat, connective tissue, and a venous plexus, which accounts for the slightly variable signal characteristics of this supra-odontoid space, or what is called or the apical. Sorry, that was a typing error. Supposed to be apical cave on MRI imaging. Okay, so when we consider this apical ligament, okay, it may be absent. What research has shown, it may be absent in about 20% of subjects based on cadaveric dissections that was undertaken by Tubbs and the others. Okay, so despite it being renowned, this ligament probably offers quite little, if any, significant contribution to craniocervical stability. So there's not so much contribution. It does not offer so much stability to the craniocervical junction. So the sixth ligament is what is called the anterior atlanto-occipital membrane. So this thin structure attaches the anterior aspect of the atlas to the anterior rim of the foramen magnum and is located immediately posterior to the prevertebral muscles. Okay. So it forms the anterior wall of the supra-odontoid space, which is very discernible on MRI assessment, owing to its content of fat and veins, as I described earlier. Okay, so which also houses the ala and the apical. Okay, sometimes also what is called the buccal ligament. So it serves to limit atlanto-occipital extension at the craniocervical junction. So when you look at its orientation and its arrangement, we find that it limits that extension at the craniocervical junction. So if this ligament is probably, or rather this membrane is probably torn or injured, there may be hyperextension at the craniocervical junction. Okay, the seventh one. Next slide. Okay, so remember the previous membrane, or rather ligament, is called the anterior atlanto-occipital membrane. So we also have the posterior. Okay, so the posterior atlanto-occipital membrane is believed to play very little part in the stability of the atlanto-occipital articulation. Okay, so the posterior atlanto-occipital membrane is important because it is highly visible on MRI assessment and also exhibits some specific anatomical features which may be misinterpreted on imaging as traumatic disruption. So it is quite important because of its characteristics, but it is not. It does not really offer any sort of stability. Rather, it offers very little stability in that region. So the broad ligament attaches. Okay, the broad ligament attaches to the posterior arch of the atlas, to the posterior arch of the atlas, to the posterior margin of the foramen magnum, and is continuous with the posterior atlanto-axial membrane, and subsequently the ligamentum flavum. Okay, so laterally, when you look at this membrane, it may extend over the capsules of the atlanto-occipital joint. So let's look at probably the last ligament, which is the 8th one, which is called the nuchal ligament. Okay, this is a cephalic extension of the supraspinous ligament, and extends from the spinous process of the C7 vertebra, attaching to the union of the occipital bone. So, so a study structure, because it is a study structure, it limits hyperflexion of the cervical spine. So, like I mentioned earlier on, there are quite a number of ligaments and membranes that are not so much described, but they are defined as more accessory ligaments, okay, as we shall see on the table that I've attached. And these are related to the craniocervical junction as well, in addition to the more substantial ligaments that I've mentioned above, okay, or rather earlier on. So while demonstrable on cadaveric dissections, both the identification of these smaller ligaments, these accessory ligaments, okay, on clinical MRI assessment, as well as the contribution of these structures to overall craniocervical junction stability is limited, and as such, injury to these ligaments in isolation is probably of low clinical significance. I think I mentioned this when I started talking about these ligaments. So these accessory ligaments, if it is injured in isolation, if it is only one of them that is injured, but the prevalence of such injuries are quite rare, or rather quite low. Okay, so we can see that if it is injured in isolation, there is very little significance clinically. So that table is showing some other membranes that are found on the craniocervical junction. Okay, so let's look at vascular supply. So arising from the subclavian artery, remember, which is a branch of the ascending aorta. Okay, so the subclavian artery gives rise to what is called to the bilateral vertebral arteries, which progress cephalad via the transverse foramina of the cervical spine. Okay, so after exiting these transverse foramina of C1, the vertebral arteries course along the superior surface of the posterior ring of the atlas before turning ventrally to puncture the atlanto-occipital membrane medial to the superior articular facet. Okay, so those basically are those are described in the blood supply. So let's look at the next slide. So we have the blood supply to the cranial vertebral junction, or the craniocervical junction, is accomplished by the extensions of the vertebral artery to the subaxial spine. Okay, so now the anterior and posterior ascending arteries branch from the vertebral artery at about C2 to C3. Okay, entering the vertebral column and giving supply to the axis before anastomosing to form the apico-odontoid arcade of these blood vessels, okay, that supply the atlas and the dens. So there is that anastomosis that is formed, okay, or rather that is formed, and this is called the apico-odontoid arcade. And this arcade is the one which supplies the atlas and the dens. So the occipital artery completes the superior portion of the arcade with minor contributions from the arteries of the skull base. So let's look at the nerve roots in this region. So the craniocervical junction houses houses the transition from the brainstem to the spinal cord. Okay, so as we described earlier on. Okay, so the major concern of instability. So when there is instability, the major concern at this region is the stenotic injury to the spinal cord and its derivatives. So the C1 nerve exits as superior to the atlas by route of a groove in the posterior ring formed by the elevation of the superior articular surface. So the vertebral artery shares this groove. So that groove through which the C1 nerves exit. Okay, it is shared by with the vertebral artery. Okay. Now the roof of which is formed by the posterior occipital Atlanto ligament, as we described when we're talking about the posterior occipital ligament. Now, when we look at C2 nerve, the C2 nerve similarly exits posterior to the superior articular facet of the axis, but more laterally than C1, the C1 nerve rather. Okay, so distal branches of the C2 and C3 nerve roots course superiorly and medially, passing superficial to the posterior craniocervical junction as the greater, lesser, and third occipital nerves. Okay, so the origins and pathways of the upper cervical vertebral nerves were charted by micro dissections. Okay, so now the C2, C3 vertebral nerves mediate pain sensation from the craniovertebral junctions ligament. So those ligaments that we mentioned, okay, the C2, C3 vertebral nerves are the ones that mediate pain in that region. Other than the ligaments, we also have soft tissues and the dura mater. So all the pain sensation coming from the ligaments, the soft tissues, and the dura mater is mediated by the C2, C3 vertebral nerves. So the C1 also contributes sensation to a small degree, okay, at the ATLANTO-OCCIPITAL joint. Now, let's look at, this is just a summary. I think it's a summary of the physiological biomechanics, okay? So when you look at the movement, the motion that is exhibited at the craniocervical junction. So these are some of the movements that are allowed at the craniocervical junction. So for example, there is the type of motion, the joint, okay? We have the joint, the first joint there, remember we talked about the occipital atlanto joint, then we have the atlanto-axial joint, okay? So now, at the occipital atlanto joint, we have about 23 to 24.5 degrees of flexion or extension. Then we also have but when you look at the C1, C2 joint, that is the atlanto-axial joint, we only have about 10.1 to about 22.4 degrees of flexion and extension. Okay, so like I mentioned earlier on, we can see that the occipital atlanto joint allows more flexion and extension as compared to the atlanto-axial joint. When we look at lateral bending, okay, we can see that there's more lateral bending at the atlanto-axial joint compared to the occipital atlanto joint. Okay, so that diagram, there are some variants. Okay, there are different variants of or rather the normal variants of the craniocervical junction. So these are from what I came across, they are described in different ways. But from my source, we can see that we have one of the variants. We can see that there's what is called the pseudo fracture of the odontoid. Okay. So this is one of the variants. So it looks as if there's a fracture of at the odontoid process, as we can see on the arrow there. Okay, so this is just, and sometimes it is also considered as what is called the biconatic odontoid. Okay, rather sometimes it can be called the biconate odontoid. Then we also have the biconate odontoid, like I've already mentioned. So this one, it is characteristic, the characteristic B-shaped cleft in the superior aspect of the odontoid, and the diamond-shaped distal ossification center of the proatlas origin as seen in the open mouth view. Okay, so we have that view B-shaped somewhere where the arrow is pointing there. Okay, so this is what is called the biconate odontoid. It is also another variant of the odontoid. Of the craniocervical junction. Okay, then we also have what is called the subdental synchondrosis. Then next we have what is called the accessory. Let's go to the next slide. Okay, we have what is called the accessory ossification center for the anterior arch of the atlas. Okay, so in this case, we see that the regular fragment located inferior to the anterior arch of the atlas in the lateral projection may be mistaken for fracture fragments. Okay, so that shouldn't be done. So the clear cortical margins and the characteristic location help to differentiate this variant from a fracture. Okay, so let's look at this is just something that I came across and decided to add. It is more of clinical application. So we have what is called craniocervical junction fixation or craniovertebral junction fixation. So in a case of injury to the craniovertebral junction, we have different fixation methods that can be seen. Okay, so due to the complex anatomical nature as well as the significant mobility of the craniovertebral junction, fixation of this region remains at times a challenging decision and a difficult execution. I'm sure probably the senior neurosurgeons may have more experience on that aspect. So a wide variety of fixation methods exist and may include a combination of the following. So we have screws, we have rods, wires or cables, we have bone graft, we have hooks, as well as plates. Okay. So furthermore, arthrodesis is also a challenge, as there is little space and bone surface for significant bone grafting. So the rest of the diagrams that we can see there in the next slide are simply showing the different fixation methods that are used when there's injury to the craniocervical junction. Okay, we can go to the next slide. Those are just the variants of these fixation methods. Next slide. Okay, next slide. Next slide. Okay, so that is the end of my presentation. Thank you so much.
Well, thank you, Dawin. Very detailed presentation. I'll first leave it to the two seniors here, who are Dr. Nuru and Dr. Kabulo, for feedback on this presentation. Dr. Nuru and Dr. Kabulo, if you have any feedback for Dawin, please go ahead.
Thank you, Dr. Hilary. Dawin, thank you so much for this beautiful presentation. It was detailed. So it was a very good presentation. I really enjoyed your presentation. So keep it high like that. Just one comment. It's sometimes you had very busy slides. If next time you can reduce, you had very, very busy slides. Yeah. Then apart from that, I have a small question for you. You said the CV joined the craniocervical.
All right.
Sorry, can you hear me?
Hello.
Hello, Dawin.
Yeah, I can hear you, Dr. Yes, I can hear you.
Yeah, it's okay. So, I'm sorry. How do you differentiate the craniocervical joint from children from adults? Just few points.
Okay. Not really that. Maybe I came across that that literature, but from what I was presenting, I think we can, if we look at the different sections of the craniocervical junction, we can see that. Remember, I mentioned. Hello.
Yes, go ahead, Dawin.
Okay, so from embryology, we mentioned that there are some regions that remain unfused up to fifth year of life. Then there are also others that remain unfused up to about the 6th year of life. So I'm not so sure how exactly it can be differentiated, but I'm just trying to derive some information from that aspect in terms of embryology. I think I need clarity on that. Hello.
So how about you've spoken about based on your presentation, you said it's about structures that are fused, right?
Yes.
Okay. So Dr. Kabulo, did you get
Hello?
Dawin's answer?
I'm sorry, Dr. Ilrik, I just got a very important call, so I was I didn't listen for the answer, but it doesn't matter. We can ask Dr. Nuru to give his comment. I was on the phone the moment he was giving the answer.
No, but well, basically what he said was the differences from what he's seen in the literature, where in terms of fusion, that certain aspects of the certain parts of the vertebrae weren't fused in the younger folks, and then in the adults were fused. If you could give him more information about that.
Okay, I was just asking about anatomically, not surgical techniques. It was just anatomically the difference, and also yeah, it was just anatomic.
Okay. Yeah, Dr. Nuru had to step out for a bit. Something came up. So just once again, great presentation. Clearly, what you found as references were amazing.
Hello?
Yes, Dawin. You need to wait a little bit because there's a delay, Dawin. So what I was saying was great presentation. Clearly, from your references and the content of your presentation, you've done a very detailed scientific review of the literature. A very, very detailed presentation. So in terms of advice, we already spoke about a few things before, as in keep your slides less busy. Actually, keep it five words at most, 5 lines at most. Try and get more images, illustrations, so that we can follow with you. You should already know some of the places you can get images. Radiopedia, for example. Radiopedia, you get free access to CT scan, radiographic images, as well as MRIs. So you can go onto Radiopedia and get those images. You can get more images from textbooks as well. As well as other videos from YouTube, for example. So something like the craniovertebral junction, you'll find out that there was a presentation available online on the YouTube page of the Young Neurosurgeons Forum. It was actually one of the first presentations that they aired out. So those are some useful resources. So altogether, really great job. Other comments, I wrote a few down. The way you wrote nerve roots, actually roots with nerve roots is R-O-O-T-S, not R-O-U-T-E-S, nerve roots. You want to avoid complete sentences as much as possible. What Dr. Marco Meloni said is very important. Let me give you an example of how you go about that. I know for you it's tough. You're thinking, how do I keep all the information? What is important? What's not important? It's not about getting everything that's important on the slides. So this here is a complete sentence. So when you were reading it, all of us were reading at the same time. We don't want to be reading with you. So if here you look and you think, okay, it's a thin structure. Okay, there's an anterior aspect. So this, for example, is something that can be or you can be showing on an image. So next time when you're presenting, you can have this as a note and have an image. So we are not reading it with you. You have the notes and you can just put a few words. The few words will be probably attached to the anterior aspect of the atlas, full stop. And then you're describing the rest of this. Okay, Dawin?
Okay.
Yes.
Sure,
So that's one way. You need to exercise yourself to do that. Exercise to distill the information as much as possible. Bring it down. Keep it as little as possible. Other things where try and be consistent in the fonts you choose for your presentation. If you're using one size for the body of your presentations, keep that size. So if you said I'm going 22, keep 22 all through. We can't have one slide being 18, another one is 22, another one is 25. Try and be consistent. Same goes with the bold.
Okay.
If you started using bold to show us that in this phrase, I want you to remember this, then you will notice that in your slides, certain slides were completely in bold, right? So try and be consistent once again.
Yes. Okay.
Yes, and if you reduce that text and have notes, because even in PowerPoint, when you do the PowerPoint, you can have notes below, so you can have your own notes. If you reduce the text and have notes, you will not be repeating yourself. You avoid repeating yourself and you captivate people. All this said, though, I mean, this is a really quality presentation. It is clear that you've done the work. It is absolutely clear from this presentation you've done the work. You've taken the time and researched the topic. You've made sure as much of the information was available. To be honest, you're still in medical school. I mean, for someone who's in medical school to present this level of neurosurgery, that has to be commended. So we are very proud to have you here, and we encourage other people to make the same efforts. Our feedback, obviously, is to make sure that you become a better presenter and you become better at what you're doing. And if you keep up this way, obviously, the sky's the limit. So thank you very much. I see Dr. Nuru.
Thank you so much, Dr. Ulrich.
Well, thank you. Dr. Nuru is back, so I'll let him give his comments, perhaps. Dr. Nuru, please go ahead.
Hi, everyone. I hope you are doing well. Thank you, Dawin, for your presentation. I think the colleague give the comment and give you a little advice. Me, I like your presentation, but you should know that anatomy, you can't present anatomy without image. Okay, all your slides should be image, and your words should be your test. That is my my recommendation for you. If not, I think you talk about everything, a lot of details, and it is nice, but you should know that next time, please, when you want to present topic like anatomy, please, you should give us more imaging. And thank you very much for your effort. And yes, I encourage you to do more than that. And thank you, Ulrich, for what you do and for the organization.
Well, thanks. Dr. Robert and Kennedy, if you have any comments, please go ahead.
Okay. I think Dawin did a great job. He's a medical student. I was just chatting with Kennedy on the sideline, and we're really appreciating, we're impressed by the detail. We concur with everyone on the issue of crowded slides, because you see the meaning of PowerPoint. You see, it's a PowerPoint. You put the points, and then you talk about them, and in that way you don't lose the crowd, you don't lose the audience. When you put so many words, eventually, you wear out the minds of the people that are watching, because they have to read everything. Actually, you present a temptation for people to read everything that you have written down in the slide. And soon people minds wear out. However, I was just sharing with Kennedy that Dawin has a great future. If he chooses to become a neurosurgeon or a spine surgeon, that level of detail was really very, very impressive. So we want you to keep it up, keep reading, keep working very hard. We're very happy we've learned much today. It's just a refresher for us. So I think this is really cool.
Yeah.
Thank you so much, Dr. Robert.
Dr. Kennedy, would you?
Yeah. Dawin, I think we must commend you for the quality presentation that you really went into those, it was a detailed, and it was clear that you'd really put a lot of effort and work into it. So I think much has been said, so I won't belabor the point, but maybe next time more of the pictures. Human beings we are more captivated by pictures than words, and we tend to will follow through. But once you put words, people minds tend to veer off and they lose you in between, because they're also trying to read with you on the slides. But other than that, thank you so much. It was a great effort.
Yeah.
Thank you so much, Dr. Kennedy. Well noted.
Before leaving, Dr. Aminata left a comment for you, Dawin. I hope you can see it, and she's equally congratulating you. So yeah, I mean, really good work, good work. But you know, we always in neurosurgery we always want to do better. So you're doing great work. We want you to do even better work. So yeah, awesome.
Yes, Dr. Ilri. Honestly, Dawin is doing well. He is doing well at his level. Even myself, when I was at his level, I couldn't present like this. So
yeah.